Fourth, under the neurodevelopmental disorders, we have the attention deficit hyperactivity disorder, which involves number 1, attention deficit hyperactivity disorder. For its diagnostic criteria, for criterion A, a persistent pattern of inattention and or hyperactivity impulsivity that interferes with functioning or development as characterized by one or two of the following. So, ang criterion A is nahati siya sa dalawa, which is the inattention, and the second one, we have the hyperactivity impulsivity. So, inattention manifests behaviorally in ADHD as wandering off task, failing to follow through or instructions, or finishing work or chores, and many more that we will discuss. So, first, we have the inattention. So, 6 sa mga symptoms na ito have persist for at least 6 months to a degree that is inconsistent with developmental level and that negatively impacts directly on social and academic or occupational activities. So, note that itong mga symptoms na to are not solely a manifestation of oppositional behavior, defiance, hostility, or failure to understand tasks or instructions. Para naman sa mga older adolescents and adults na nag-iedad ng 17 and older, at least 5 ng symptoms ang required. So, letter A, often fails to give a close attention to details or gumagawa ng mga careless mistakes sa schoolwork, sa work, or during other activities. Second one, meron silang difficulty sustaining attention in tasks or play activities. Third one, they often does not seem to listen when spoken to directly. Fourth, often they do not follow through on instructions and nagfe-fail sila na ma-finish ang schoolwork, chores, or duties in the workplace. Fifth, often merong difficulty organizing tasks and activities. Sixth, we have they often avoid, dislike, or is reluctant to engage in tasks that nagre-require ng sustained mental effort. Seventh, kalimitan nilang nawawala ang mga things that is necessary para matapos ang tasks or activities. Eighth, they are often easily distracted by extraneous stimuli. For older adolescents and adults, it involves or includes unrelated thoughts. Next one, you have they are forgetful ng kanilang mga daily activities. Second one, we have the hyperactivity and impulsivity. So, hyperactivity refers to excessive motor activity such as a child running about when it is not appropriate, or excessive fidgeting, tapping, or talkativeness. In adults, hyperactivity may manifest as extreme restlessness or wearying others with their activity. So, impulsivity naman refers to hasty actions that occur in the moment without forethought, which may have potential for harm to the individual. So, impulsivity may reflect a desire for immediate rewards or an inability to delay gratification. So, impulsive behaviors may manifest as social intrusiveness and or as making important decisions without consideration of long-term consequence. So, for the hyperactivity and impulsivity, 6 or more of the following symptoms have persisted for at least 6 months to a degree that is inconsistent with developmental level and that negatively impacts directly on social and academic occupational activities. So, for older adolescents and adults, age 17 and older, at least 5 na symptoms ang required. So, here are the symptoms. Letter A, often fidgets with or taps hands or feet or screams in sit. Second, often, umaalis sila sa kanilang upuan in situations na dapat ay nakaremain sila na seated. Letter C, they often run or climbs in situations na hindi naman yun appropriate, na kailangan tumakbo or umakyat sila. Fourth one, often unable to play or engage in leisure activities quietly. 6, they are often on the go, acting as if they were driven by a motor. Next, they often talk excessively. Next, they often blurts out an answer before na binibigay yung o natatapos yung isang question. Next, na nahihirapan sila na maghintay ng kanilang turn. And next, they often interrupts or intrudes on others. So for criterion B, several inattentive or hyperactive impulsive symptoms were present prior to age 12 years. So, ADHD begins in childhood. The requirement that several symptoms be present before age 12 years conveys ng importance ng substantial clinical presentation during childhood. At the same time, an earlier age at onset is not specified because of difficulties in establishing precise childhood onset retrospectively. So, adult recall of childhood symptoms tends to be unreliable, and it is beneficial to obtain ancillary information. So, ADHD cannot be diagnosed in the absence of any symptoms prior to age 12. When symptoms naman of what appears to be ADHD first occurs after the age of 13, they are more likely to be explained by another mental disorder or to represent the cognitive effects of substance use. For criterion C, several inattentive or hyperactive impulsive symptoms are present in two or more settings. So, confirmation of substantial symptoms across settings typically cannot be done accurately without consulting informants who have seen the individual in those settings. So, typically, symptoms vary depending on context within a given setting. For criterion D naman, there is a clear evidence that the symptoms interfere with or reduce the quality of social, academic, or occupational functioning. And lastly, for criterion E, the symptoms do not occur exclusively during the course of schizophrenia or another psychotic disorder and are not better explained by another mental disorder. On the YouTube video of Dr. Dawn Snipes, she gave mnemonics for the symptoms of attention deficit hyperactivity disorder. So we have here the 1266, or that the 12 years or younger when symptoms start. Then 6 or more symptoms in multiple settings. For for 17 years old and older, it must be 5 or more symptoms is present. Next, another number 6, or for the 6 months or more that yung symptoms is persist. Next, we have for the inattention, we have the scaffold, spelled as SCAFFOLLD. Nag-double L lang siya. So, we have S for sustained mental effort avoided, C for careless mistakes or poor attention to details, A for attention not sustained in tasks or play activities, F for forgetful in daily activities, F for follow-through lacking or sidetracked, O for organizing difficult time and task, L for listening poor when spoken to directly, L for loses things necessary for tasks, D for distracted easily by extraneous stimuli. For hyperactivity impulsivity naman, we have run too fast, spelled as RUNTO lang siya, hindi siya yung TOO, and fast, FAST. Runs or is restless, U for unable to wait turn, N for noisy or being not able to play quietly, T for tends to interrupt, O for on the go, F for fidgets or squirms, A for answers blurted out, S for sitting is difficult, and T for talks excessively. For its specifiers, for F90.2 combined presentation. So, this specifier is diagnosed if both criterion A1 or the inattention and criterion A2 or hyperactivity impulsivity are met for the past 6 months. For F90.0 or predominantly inattentive presentation, this criteria or this specifier is diagnosed if na-met yung criterion A1 which is inattention pero hindi na-meet yung criterion A2 which is the hyperactivity impulsivity for the past 6 months. For F90.1, predominantly hyperactive impulsive presentation. So, ito ay yung if ang criterion A2 naman ang na-meet which is the impulsivity pero hindi na-meet yung criterion A1 which is the inattention for the past 6 months. So, also specify if in partial remission. When full criteria were previously met, fewer than the full criteria have been met for the past 6 months, and the symptoms still result in impairment in social, academic, or occupational functioning. Also, specify current severity. If mild,
It means that few, if any, symptoms in excess or those required to make the diagnosis are present, and symptoms result in no more than minor impairments in social or occupational functioning. For moderate, symptoms of functional impairment between mild and severe are present, and for severe, many symptoms in excess of those required to make the diagnosis, or several symptoms that are particularly severe are present, or the symptoms result in marked impairment in social or occupational functioning. For the associated features, delays in language, motor, or social development are not specific to ADHD but often co-occur. So, emotional dysregulation or emotional impulsivity commonly occurs in children and adults with ADHD. So, yung mga individual na may ADHD, nag-self-report sila and they are described by other people as being quick to anger, easily frustrated, and overreactive emotionally. Also, academic or work performance is often impaired and may exhibit neurocognitive deficits in variety of areas. So, children na mayroong neurodevelopmental disorders with a known cause may often also have symptoms of inattention and impulsivity, hyperactivity. They should receive an ADHD diagnosis if their symptoms meet the full criteria for the disorder. So for the prevalence, population surveys suggest that ADHD occurs worldwide in about 7.2% of children. However, cross-national prevalence ranges widely from 0.1% to 10.2% of children and adolescents. So prevalence is higher in special populations such as foster children or correctional settings. In a cross-national meta-analysis, ADHD occurred in 2.5 of adults. So, development and course. So, symptoms are difficult to distinguish from highly variable normative behaviors before age 4 years. ADHD is most often identified during elementary school years. In preschool, the main manifestation is hyperactivity. Inattention becomes more prominent siya during elementary school. During adolescence naman, signs of hyperactivity are less common and may be confined to fidgetiness or an inner feeling of jitteriness, restlessness, or impatience. In adulthood naman, along with inattention and restlessness, impulsivity may remain problematic even when hyperactivity has diminished. So for the risk and prognosis factors. So, temperamental. ADHD is associated with reduced behavioral inhibition, effortful control, or constraint, negative emotionality, and or elevated novelty seeking. These traits may predispose some children to ADHD but are not specific to the disorder. For the environmental, very low birth weight and degree of prematurity convey a great risk for ADHD. The more extreme the low weight, the greater the risk. Prenatal exposure to smoking is associated also with ADHD even after controlling for parental psychiatric history and socioeconomic status. So, a minority of cases may be related to reactions to aspects of diet. Neurotoxin exposure, infections, and alcohol exposure in utero have been correlated with subsequent ADHD, but it is not known whether these associations are causal. For the genetic and physiological, the heritability of ADHD is approximately 74%. Large-scale genome-wide association studies, or the GWAS, have identified a number of lossy enriched in evolutionary constrained genomic regions and loss of function genes as well as around brain expressed regulatory regions. So there is no single gene for ADHD. Visual and hearing impairments, metabolic abnormalities, and nutritional deficiencies should be considered as possible influences on ADHD symptoms. ADHD is elevated in individuals with idiopathic epilepsy. For the course modifiers, so family interaction patterns in early childhood are unlikely to cause ADHD, but may influence only its course or contribute to secondary development or conduct problems. For the culture-related diagnostic issues, differences in ADHD prevalence across regions appear attributable mainly to different diagnostic procedures and methodological practices. This is also affected by cultural variation in attitudes toward behavioral norms and expectations of children and youth in different social contexts, as well as cultural differences in interpretations of children's behavior by parents and teachers, including differences by gender. For the sex and gender-related diagnostic issues, so ADHD is more frequent in males than in females in the general population, with a ratio of approximately 2:1 in children and 1.6:1 in adults. Females are more likely than males to present. Females are more likely than males to present primarily with inattentive features. Sex differences in ADHD symptom severity. Sex differences in ADHD symptom severity may be due to differing genetic and cognitive liabilities between sexes. For the diagnostic markers, so no biological marker is diagnostic for ADHD, and no form of neuroimaging can be used for diagnosis of ADHD. So association with suicidal thoughts or behavior. So ADHD is a risk factor for suicidal ideation and behavior in children. Similarly, in adulthood, ADHD is associated with an increased risk of suicide attempt when comorbid with mood conduct or substance use disorders, even after controlling for comorbidity. So suicidal thoughts are also more common in ADHD population than in non-ADHD control subjects. For the functional consequences of ADHD, ADHD is associated with reduced school performance and academic attainment. Young adults with ADHD have poor job stability. Family relationships may be characterized by discord and negative interactions. Children with ADHD are significantly more likely than their peers without ADHD to develop conduct disorder in adolescence and antisocial personality disorder in adulthood, consequently increasing the likelihood for substance use disorders and incarceration. So individuals with ADHD are more likely than peers to be injured. For the differential diagnosis, oppositional defiant disorder. So their behavior is characterized by negativity, hostility, and defiance. Complicating the differential diagnosis is the fact that some individuals with ADHD may develop secondary oppositional attitudes towards such tasks and devalue their importance. For the intermittent explosive disorder, ADHD and intermittent explosive disorder share high levels of impulsive behavior. However, individuals with intermittent explosive disorder show serious aggression toward others, which is not a characteristic of ADHD po, and they do not experience problems with sustaining attention as seen in ADHD. In addition, intermittent explosive disorder is rare in childhood. Intermittent explosive disorder may be diagnosed in the presence of ADHD. For the other neurodevelopmental disorders, in stereotypic movement disorder, the motoric behavior is generally fixed and repetitive, whereas the fidgetedness and the restlessness in ADHD are typically generalized and not characterized by repetitive stereotypic movements. So in Tourette's disorder naman, frequent multiple tics can be mistaken for the generalized fidgetiness of ADHD. So prolonged observation may be needed to differentiate fidgetiness from bouts of multiple tics. For specific learning disorder naman, children with specific learning disorder alone may appear inattentive because of frustration, lack of interest, or limited ability in neurocognitive processes, including working memory and processing speed, whereas their inattention is much reduced when performing a skill that does not require the impaired cognitive process. For intellectual developmental disorder naman, symptoms of ADHD are common in children with intellectual developmental disorder placed in academic settings that are inappropriate to their intellectual disability. In such cases, the symptoms are not evident during non-academic tasks. A diagnosis of ADHD in intellectual developmental disorder requires that inattention or hyperactivity be excessive for mental age. For autism spectrum disorder naman, the social and peer rejections in individuals with ADHD must be distinguished from the social disengagement, isolation, and indifference to facial and tonal communication cues seen in individuals with autism spectrum disorder. So, children with autism spectrum disorder may display tantrums because of an inability to tolerate a change from the expected course of events. Yung mga children with ADHD naman may misbehave or have a tantrum during a major transition because of impulsivity or poor self-control. For reactive attachment disorder naman, children with reactive attachment disorder may show social disinhibition but not the full ADHD symptom cluster and display other features such as a lack of enduring relationships that are not characteristic of ADHD. For anxiety disorders, individuals with ADHD are inattentive because of their preferential engagement with novel and stimulating activities or preoccupation with enjoyable activities. So this is distinguished from the inattention attributable to worry and rumination seen in anxiety disorders. So restlessness might be seen in anxiety disorders. However, in ADHD, the symptom is not associated with worry and rumination. Next, we have post-traumatic stress disorder. Children younger than 6 years often manifest PTSD in non-specific symptoms such as restlessness, irritability, inattention, and poor concentration, which can mimic ADHD. So parents may also minimize their children's trauma-related symptoms, and teachers and other caregivers are often unaware of the child's exposure to traumatic events. A comprehensive assessment of past exposure to traumatic events can rule out PTSD, or the post-traumatic stress disorder. For depressive disorders, individuals with depressive disorders may present with inability to concentrate. However, poor concentration and mood disorders become prominent only during a depressive episode. For bipolar disorder, individuals with bipolar disorder may have increased activity, poor concentration, and increased impulsivity, but these features are episodic, unlike ADHD, in which the symptoms are persistent. For disruptive mood dysregulation disorder, so disruptive mood dysregulation disorder is characterized by pervasive irritability and intolerance of frustration, but impulsiveness and disorganized attention are not essential features. However, most children and adolescents with the disorder also have symptoms that meet criteria for ADHD, which is diagnosed separately. For substance use disorders, differentiating ADHD from substance use disorders may be problematic if the first presentation of ADHD symptoms follows the onset of abuse or frequent use. Clear evidence of ADHD before substance misuse from informants or previous records may be essential for differential diagnosis. For personality disorders, some personality disorders tend to share the features of disorganization, social intrusiveness, emotional dysregulation, and cognitive dysregulation. However, ADHD is not characterized by fear of abandonment, self-injury, extreme ambivalence, or other features of personality disorder. It may take extended clinical observation, informant interview, or detailed history of distinguished impulsive, socially intrusive, or inappropriate behavior from narcissistic, aggressive, or domineering behavior to make this differential diagnosis. For psychotic disorders, ADHD is not diagnosed if the symptoms of inattention, hyperactivity occur exclusively during the course of a psychotic disorder. For medication-induced symptoms of ADHD, symptoms of inattention, hyperactivity, impulsivity attributable to the use of medication are diagnosed as other specified or unspecified other substance. Neurocognitive disorders. While impairment in complex attention may be one of the affective cognitive domains in a neurocognitive disorder, it must represent a decline from a previous level of performance in order to justify a diagnosis of major or mild neurocognitive disorder. Moreover, major or mild neurocognitive disorder typically has its onset in adulthood. In contrast, the inattention in ADHD must have been present prior to age 12 and does not represent a decline from previous functioning. For comorbidity, females with ADHD have higher rates of a number of comorbid disorders, particularly oppositional defiant disorder, autism spectrum disorder, and personality and substance use disorders. ADHD may co-occur in variable symptom profiles with other neurodevelopmental disorders, including specific learning disorder, autism spectrum disorder, intellectual developmental disorder, language disorders, developmental coordination disorder, and tic disorders. Comorbid sleep disorders in ADHD are associated with daytime impairments in cognition. So individuals with ADHD have been found to have elevated rates of a number of medical conditions, particularly allergy and autoimmune disorders, as well as epilepsy. So researchers have known for some time that ADHD is more common in families in which one person has that disorder. So there is a strong evidence na ang ADHD daw is associated with the dopamine D4 receptor gene, the dopamine transporter gene, and the dopamine D5 receptor gene. So the DAT1 or the dopamine transporter gene is of particular interest because of methylphenidate or the Ritalin, or it is one of the most common medical treatments for ADHD. So it inhibits this gene and increases the amount of dopamine available. Researchers found that children with a specific mutation involving the dopamine system were more likely to exhibit the symptoms of attention deficit hyperactivity disorder if their mothers smoked during pregnancy. Researchers now know that the overall volume of the brain in those with this disorder is slightly smaller, of about 3% to 4% than in children without the disorder. So a number of areas in the brains of those with attention deficit hyperactivity disorder appear affected, especially those involved in self-organizational abilities. So one study found that 3-year-old and 8 to 9-year-old children who consumed typical amounts of preservatives and food colorings had increased levels of hyperactive behaviors. Other research naman now points to the possible role of toxins such as the pesticides found in foods as contributing to an increased risk of attention deficit hyperactivity disorder. Negative responses by parents, teachers, and peers to the affected child's impulsivity and hyperactivity may contribute to feelings of low self-esteem, especially in children who are also depressed. So years of constant reminders by teachers and parents to behave or to sit quietly and pay attention may create a negative self-image in these children, which in turn can negatively affect their ability to make friends, and these effects can last into adulthood. Para naman sa treatment. So, treatment for attention deficit hyperactivity disorder has proceeded on two fronts. We have the psychosocial and the biological interventions. For psychosocial interventions, other parent education programs teach families how to respond constructively to their children's behavior and how to structure the child's day to help prevent difficulties. So social skills training for these children, which includes teaching them how to interact appropriately with their peers, also seems to be an important treatment component. Para naman sa adults with attention deficit hyperactivity disorder, cognitive behavioral intervention to reduce destructibility and improve organizational skills appears quite helpful. Most clinicians typically recommend a combination of approaches designed to individualize treatments for those with attention deficit hyperactivity disorder, and targeting both short-term management issues and long-term concerns.
For biological interventions naman, the first types of medication used for children with attention deficit hyperactivity disorder were stimulants. It is estimated that 3.5% of the children living in United States are being treated with medication for symptoms of attention deficit hyperactivity disorder. So, drugs such as methylphenidate or the Ritalin and several non-stimulant medications such as atomoxetine and clonidine have proved helpful in reducing the core symptoms of hyperactivity and impulsivity and improving concentration on tasks. So it appears that stimulant medications reinforce the brain's ability to focus attention during problem-solving tasks. Although the use of stimulant medications remains controversial, especially for children, most clinicians recommend them temporarily in combination with psychosocial interventions to help improve children's social and academic skills. So, initial reports from the study suggested that yung combination ng behavioral treatments and medication were superior sa medication alone or sa behavioral treatment alone and sa community intervention for ADHD symptoms. So, reinterpretations of the data from this large-scale study continue, and more research likely will be needed to clarify the combined and separate effects of these two approaches to treatment. All in all, for the causes of attention deficit hyperactivity disorder, research suggests there are hereditary factors. There are also abnormal neurology, possible link with maternal smoking, and causes may include negative responses by others which create low self-esteem. For the treatment naman, biological or medication includes improves compliance, decreases negative behaviors, and effects are not long term. For psychological or behavioral naman, it includes goal setting and reinforcement. So, under the attention deficit hyperactivity disorder, we have also the other specified attention deficit hyperactivity disorder, F90.8. So, clinically significant distress or impairment in social, occupational, or other important areas of functioning predominate but do not meet the full criteria. So, clinician chooses to communicate the specific reason. So, other specified attention deficit hyperactivity disorder followed by the specific reason. So, yan po yung pag-record ng diagnosis. Yung other specified attention deficit hyperactivity disorder followed by the specific reason. Example, other specified attention deficit hyperactivity disorder with insufficient inattention symptoms. For the unspecified attention deficit hyperactivity disorder naman, or F90.9, symptoms, characteristics of attention deficit hyperactivity disorder that cause clinically significant distress or impairment in social, occupational, or other important areas of functioning predominate but do not meet the full criteria. So, clinician chooses not to specify the reason. So, insufficient information to make a more specific diagnosis. So, yung sa other specified ADHD, clinician chooses to communicate the specific reason, while in unspecified naman, the clinician chooses not to specify the reason, and there is an insufficient information to make a more specific diagnosis. For the summary, in intellectual developmental disorders, merong deficits in general mental abilities. In communication disorders naman, there are deficits in the development and use of language, speech, and communication. Sa autism spectrum disorder naman, there is a persistent deficit in social communication and social interactions across multiple contexts. As attention deficit hyperactivity disorder naman, impairing levels of inattention, disorganization, and or hyperactivity or impulsivity occurs.